We'll go ahead and get started. So like I said, welcome to the afternoon session, day 2 of the Children's Week virtual conference. I'm Dr. Ruth Adewuya. I'm the Managing Director for the Center for CME here at Stanford, and I'm very pleased that you are joining us for this session. Just a few housekeeping things. We will be asking you to put your questions for our speakers in the Q&A portion of the Zoom. So if you look below your screen, you'll see a Q&A button, and that's how we want you to ask questions of our speakers. They may address it as they go along, or may take some time at the end of the session to address those questions as well. We are offering CME credit for this activity. There's nothing that you have to do. You'll receive an email tomorrow with instructions on how you can claim CME if you would like to. And I will turn it over to Dr. Sarasnak to do introductions.
Thanks, Ruth. Thanks for having us. So we're going to talk about the evaluation and management of pediatric cardiac arrhythmias today. I'm Scott Sarasnak. I'm Associate Professor of Pediatrics and Pediatric Cardiology at Stanford. My partner in crime today is Heather Giacconi, who we are thrilled will be starting as faculty at Stanford in about 3 weeks. So thanks for joining us here today, and I'm going to let Heather start it off.
Perfect. All right, I'm going to share my screen here. Thank you again so much for having us today. We're really excited to talk about this topic. It's near and dear to our hearts, of course, being an EP. So I just want to make sure that everyone is aware that we do not have any disclosures, but we will be discussing several commercially available products. So we're not specifically endorsing one or the other, but just providing information about what is available currently. So our outline today, we're going to go over 4 case-based cases that we're going to go through the management of arrhythmias. The first being palpitations. Second is the presentation of syncope in the clinic setting. Third, we're going to touch upon myocarditis. And then the fourth one is where we are going to delve into what type of wearable monitors we have and ECG tracings that we can have at home for our patients. So I'll jump into the first case. So we have an 11-year-old female. She's previously healthy. She presents to you with palpitations directly after intense exercise, she says. This is a very, very athletic girl. She's actually a competitive speed skater, and she has nationals coming up in about 3 weeks. When chatting with her, she says these palpitations sometimes come out just out of the blue while she's sitting there watching TV, but mainly it's after exercise. Usually lasts about 5 to 10 minutes in duration. One really important thing to always ask that we did during this session was to ask how it starts and how it stops. Is this a gradual onset or is it a sudden onset? And she says, one beat it's normal, and the next beat it's off to the races. And that's exactly how it stops as well. So there's a very sudden, clear offset that she feels. The other thing we always like to hone upon and have a great history for is how she feels during these episodes. She says more often than not, she is actually dizzy and a little bit lightheaded with these feelings. She doesn't have any significant past medical history or family history. There's no history of sudden cardiac death within her family, early myocardial infarctions, no known channelopathies or arrhythmia syndromes within her family as well. And it's always very critical to screen our adolescents, even though she's 11, if she has any sort of use for drugs of abuse or supplements, especially the higher performing athletes. And again, she kind of reiterates, exercise is my life, speed skating is my life, and I want to get back to it ASAP. Actually, she was on her way to practice right after our appointment. She did have a normal physical examination and vitals. So you get an EKG for her. And so things to think about for this EKG and what jumps out directly with you is you start to see this delta wave. So you see a short PR interval and this slurring upwards, this delta wave or ventricular pre-excitation. You can actually see it in many different leads. And I just pointed out a few here. So she is a case of likely Wolff-Parkinson-White syndrome. To classify Wolff-Parkinson-White syndrome, these patients do have a short PR interval, so less than 120 milliseconds. And this is really caused by the rapid conduction through this accessory pathway, or a small area of fibers that crosses this fibrous ring of the valves here and allows for electricity to excite the ventricle before the normal conduction system does. So this early ventricular activation, you can see, causes this delta wave. And then as the normal conduction system catches up, there's a fusion or a summation of how those signals are sent down to the ventricle and how it actually depolarizes. Anytime that you're depolarizing the ventricle in an abnormal fashion, you can get also abnormal repolarization as well. So it is, you'll have to note on the EKG that you can have actually T-wave abnormalities or inversions as well when you're seeing this. So how many people have WPW? So based off of the current literature, we know that about 1 to 3 people out of about 1,000 have WPW. It is more common in the neonatal population. The embryology for that reason is we think that those fibrous rings of the tricuspid and mitral valves are actually immature at birth. And so neonates can be born having those small areas where that myocardium still allows for electrical conductivity. And about 70% of neonates who do have accessory pathways or WPW, they're gone by 1 year of life. But we do follow them throughout our clinics. There is association with congenital heart disease, specifically Epstein's anomaly, as well as mitral valve prolapse. So about 10 to 20% of patients with Epstein's have 1 or more accessory pathways, and mainly on the right side, which makes sense for that abnormally formed tricuspid valve. For mitral valve prolapse, again, it is commonly associated with left-sided pathways. There is a very, very small population or families who have familial WPW, or it's actually an inherited manner. So you can see that the LAMP2 gene or the PRKAG2 gene are 2 commonly associated ones that fall into that category. I do have to stress this is very, very rare. The large portion of these cases of WPW are actually sporadic in nature and mainly because of how that fibrous ring forms. I do want to just make a mention as well that you can actually have heart failure from pre-excitation. This is extraordinarily rare to see as well. And then we'll touch base on why this is clinically important to catch on our EKGs, because it does and can lead to sudden cardiac arrest. Before we get to sudden cardiac arrest, I do want to touch base on the arrhythmia potential for this extra accessory pathway. So there's 3 different rhythms that I'd like to touch upon right now. The first being 2 types of SVT. So it's 2 types of supraventricular tachycardia. The first being orthodromic reentient tachycardia. You can see this narrow complex tachycardia. And this is, I don't know if you can see my pointer. Can you guys see my pointer? Okay. So this is mainly caused by PAC or some sort of early beat, most commonly, that then goes down the normal conduction system and it goes back up this accessory pathway. It creates this circuit here that takes over above the signals from the sinus node and gets into a circuit. And so you have that tachycardia or SVT. WPW pathways are very specific in how they can conduct electricity. And one thing that is very unique to them is they can actually conduct electricity in both directions. And so these patients also have the risk of having antidromic reentient tachycardia. And you can see this is actually a wide complex tachycardia. It's still SVT, but it goes down now from atrium to ventricle for this rhythm and goes the opposite way for the circuit here. The third rhythm that I really want to touch base on today is this very irregular but wide pattern that you see here. and very quite fast for this patient. So this is actually pre-excited atrial fibrillation. And so what happens is when these patients, or if these patients go into atrial fibrillation, again, that pathway, being that it can conduct electricity in both directions, now can see these signals and conduct it from the atria down to the ventricle. And depending on how quickly the pathway can actually do this, this could actually lead to ventricular fibrillation. Much so in our adult population, we're always worried about atrial fibrillation with rapid ventricular conduction, so allowing that ventricle to beat faster. But even more so in patients with WPW, because a lot of times these pathways are very much unregulated, and if they can go quite fast, so can the ventricle. So that is one of the main causes as to why WPW patients actually can encounter sudden cardiac arrest events. Sudden cardiac arrest events happen in about 1 out of 1,000 patient years in adults, or about 0.13% per year, per patient year. So thinking about 1% for the risk. So life-threatening events are actually more common with patients who have what we call higher risk pathways, which we'll touch based upon in a little bit, but it just means that there are properties of these pathways that allow for very rapid conduction. Also, if patients are on longer-term primary EV nodal blocking agents or medications such as digoxin or verapamil without any other medications on board. And to note, up to about 65% of these patients were actually asymptomatic prior to their life-threatening event. Some patient characteristics, it was a higher incidence in males, congenital heart disease, younger patients within the first 3 decades, familial WPW if they had multiple accessory pathways, and a history of atrial fibrillation or SVT. So how do we as pediatricians figure out how to risk stratify these patients? Who's actually at risk for sudden cardiac arrest and who do we not have to worry about? And so this question has actually changed throughout the years. So I'm going to take a case now. Say she had intermittent pre-excitation on her EKG, meaning that some beats you actually do see that delta wave and some you don't, and it's just normal. And then also on an exercise test, what we're looking for is that higher heart rates. At what point do you actually just lose pre-excitation? Previously, we thought that loss of pre-excitation means that the pathway is weaker or can't conduct properties as fast. So mentally, you're thinking about it and saying, okay, well, if it can't conduct as quickly, maybe they are low risk and they don't have significant risk for sudden cardiac death. But we actually have now known that loss of ventricular pre-excitation during these testing in non-invasive waves actually does not exclude high-risk accessory pathways. And so Dr. Sostek was actually involved with this multi-center study of WPW in children. And we did see that about 13% of patients with intermittent pre-excitation actually did demonstrate high-risk criteria at an EP study. And these patients also did experience sudden cardiac arrest. So now what do we do? So now we're going to actually refer them for an EP study. And this is probably one of the most important and gold standard methods we have to really not only determine how risky this pathway is for this patient, but also we can get rid of it. So we can ablate it. And that is the most rewarding thing that I can say that we do in our day-to-day is counseling these patients that we can actually go in there and get rid of this problem for them. So I'm not going to get into the nitty-gritty of this, but there are different things that we look at while we're in the lab. And this is just showing you what we're looking at when we're there. And so you can see we have some of our surface EKGs up there, and we actually have catheters in multiple locations. So this is actually in the coronary sinus. This is where the hiss is, and this is actually our ablation catheter. And as you can see, this pattern So here are all of our atrial signals, and here are all of our ventricular signals here in this row, atrial, ventricular. And you notice that this beat is different. And so this means that we're ablating up here, that the energy is being delivered, and that sudden change means that we were on the correct spot. We were actually able to get rid of that pathway. This correlates, we do actually make 3D maps when we're doing the EP study. We can see the right atrium here, this coronary sinus where we have the catheter, the tricuspid valve, and we actually did have to go across to the left side of the atrium on this mitral valve annulus and find these areas and ablate. So fortunately, we were able to get rid of that accessory pathway for her, and to date, it has still been gone. So is all that glitters is gold? Is everything that's pre-excited WPW syndrome? And the answer is no. So there are different types of pathways depending on where they kind of branch off of the normal conduction system. Some of them still have a risk for SVT, and then others actually don't. So this is actually even further reason to undergo an EP study to really determine this. There have been studies to try to say, well, if we look at a surface ECG, can we see these differences? And unfortunately, at this point, it doesn't hold out to be true always. So it is a reason to screen them from an EP standpoint. So our takeaway points for WPW, so patients with WPW are at risk for multiple types of arrhythmias that we chatted about. So we have our SVTs, as well as atrial fibrillation can lead to ventricular fibrillation that can put them at increased risk of sudden cardiac arrest. Attaining an echo to rule out structural heart disease will be important for these patients. The sudden death risk is about 1%, and intermittent pre-excitation does not always indicate a low risk pathway. An EP study is needed. Thank you. I will turn it over to Scott now to do case number 2.
Great, thanks, Heather. That was excellent. Hopefully everyone can see my screen here. So my case is going to be a case of syncope. Thanks again, Heather. So I'm going to start with a 16-year-old male who you have followed his whole life, has been previously healthy, has had no symptoms whatsoever. And they're coming to you because he had an episode of syncope while playing soccer. So the scenario was he was in a soccer game, it was a big tournament, he was chasing after the ball, he was a forward, getting ready to score, in the middle of running, suddenly collapsed. He seemed to be unconscious for about 30 to 60 seconds. At first, people didn't quite realize what was happening, and everyone sort of came around. After about 30 to 60 seconds, he sort of came to. When he woke up, he doesn't really remember anything. The last thing he remembers was running after the ball. So he had really no prodromal symptoms before that. Looking at his history, he has never had any medical issues before, has never had any surgeries. He took a little more detailed family history, and he also realized that his cousin died at 23 years of age while playing in a pickup basketball game with friends. Again, getting a little more detailed social history, he interrogated him. He's denied any drugs of abuse. He was not taking any supplements or anything else. And on your physical examination, your vitals, everything was normal and everything looked fine. So you sent him to cardiology, and we saw him in our cardiology clinic, and our baseline EKG was normal. Our echocardiogram was normal. We did a Zio patch, which is an extended heart rhythm monitor. The patient wore that for 14 days. That was normal. And then we decided to do an exercise test. And this is what we saw on the exercise test. And I think even the non-cardiologists in the room will see there's clearly something abnormal with that EKG on the bottom. And so, as you can see, the patient started to have extra beats of PVCs. They occurred more frequently. And this patient had CPVT, or catecholinergic polymorphic ventricular tachycardia. And that's why the patient passed out. So let's talk a little bit about syncope and syncope in pediatric patients. Syncope is a common problem in children and a common problem in our pediatric patients. It is one of the more common reasons for an emergency room visit. Pediatric syncope comprises about 1 to 3% of all ER visits in the United States. And I think this statistic is particularly striking, is that about 15% of kids will have one syncopal event by the time they've reached adulthood. So by the time they're 18, about 15% of kids will have one syncopal event. Now, we're going to focus on some cardiac concerns and figuring out, what would be a scary or cardiogenic cause of syncope versus not. But the vast majority of syncope in children is neurocardiogenic or vasovagal. That comprises about 3/4, and in some series up to 90% of patients, pediatric patients who have syncope. So most pediatric patients who have syncope are not going to have a true cardiac pathologic reason for them to pass out. If you look at the data, looking at what are the cardiac causes of syncope, so it's only about, in this series, it was about 4%. So actually the minority of patients who actually have a syncopal event are going to have a true cardiac cause of that syncope. And neurocardiogenic syncope clearly makes up the most common reason and cause for syncope in children. And so what are the 3 most important components of the workup for syncope? And I'll pose that, and this is how I would pose it to our fellows. Well, number 1 would be history. Number 2 would be history. Number 3 would be history. So clearly, you guys in the office, when you're seeing patients, the history here is one of the most important parts of this workup. Only after a really detailed, rich history that can really provide so much insight into the syncopal cause would we think about other testing. And then that other testing would be a detailed physical examination, right? Looking for a systolic murmur, a click, a gallop, anything that would be indicative of a cardiac cause of the syncope. Then looking at an EKG, they're presented in a great case of WPW, but looking for LVH and hypertrophic cardiomyopathy and other signs on the EKG that there may be something wrong with the heart. Then we talk about potentially an echo, extended rhythm monitor, or exercise testing. So clearly we have a stepwise approach to our workup of the patient in syncope. And so I mentioned detailed history, and I do want to spend a minute here just talking about what we're looking for in a really detailed history to give us a sense of, is this a cardiogenic cause or not? And I think we really break it up into 3 groups, the details of the event, what additional factors could be at play here, and then cardiac specific questions. And the event details are really, when did it occur? Did it occur with rest or with exercise? And the patient that I just shared was in the middle of running. The patient who stops and walks to get a drink of water is very different than the patient who's in the middle of actual running. Did they have convulsions? And cardiogenic syncope, you can see seizures associated with it as well. Did the witnesses who were there, did they call 911? Were they that worried about it? Was there any loss of bowel or bladder continence? When did it occur? Was it first thing in the morning when they woke up and stood up out of bed? And then was any intervention required? Did someone do chest compressions, right? It'd be a very different scenario than they bounce right back up. And then, what are some other additional factors? Are there other medical issues that could be at play? Are they on medications? Have they been compliant with any of their medications? Could drugs or alcohol have been involved? Could supplements that could be a problem and be a contributing factor? And then the cardiac specific questions that we would want to know would be, was there a prodrome? Did they get dizzy and feel numbness and tingling and hear funny noises? Did they have palpitations, chest pain beforehand? Were they lightheaded? Did they see any visual changes? This patient that I just described had a really concerning family history. So the family history is very important. And these cardiac specific questions are going to be really important to really delve into whether this is a cardiac cause or a non-cardiac cause of syncope. Now, as I mentioned, the most common cause of syncope in children is neurocardiogenic or also vasovagal. Often there is a prodrome. They often will have all these constellation of findings sort of classical with vasovagal syncope. So they can feel a little nauseated. Often we'll go from sitting to standing with orthostatic changes. They can feel warm and sweaty. They can feel a little dizzy and lightheaded, like they could pass out. They may be described as very pale. They may hear ringing in the ears. They may see tunnel vision. So these are all common sort of classic symptoms that are associated with vasovagal or neurocardiogenic syncope in children. So what are the red flags? Right? We talked about neurocardiogenic being the most common cause in children, but there are some things that, if anything on this list comes up, would warrant referral to cardiology for further cardiac workup. And so here's a listing of these red flags. So a prior history of heart disease. So if they have a big scar in their chest and had tetralogy of Fallot surgery, whether there's a family history of sudden or unexplained death. As I mentioned, syncope with exercise, especially in the middle of running, is quite concerning. Syncope while sitting or driving. We often see syncope with postural changes, going from sitting to standing. That's very often neurocardiogenic or postural syncope. But while sitting or driving is very concerning. Having precipitating palpitations or precipitating chest pain or shortness of breath. If you have done an EKG in your office and you see EKG abnormalities, that would obviously be a red flag. And then a prior history of unexplained syncope can also be. And in our particular case, our patient had 2 red flags, right? Syncope with exertion and a family history of sudden and unexplained death. And so I think we break up the causes of syncope in that benign group, which we just talked mostly about, and then vasovagal being a big contributor there. And then looking at the rhythm, could there be rhythm problems that contribute to syncope? So supraventricular tachycardia, ventricular tachycardia, as I mentioned, heart block, and other arrhythmogenic syndromes and inherited arrhythmia syndromes, such as long QT, brugada, CPPT, and other things that can cause rhythm problems. And there's also the structural functional problems, like cardiomyopathies, aortic stenosis, pulmonary hypertension, myocarditis, coronary artery abnormalities. All these structural and functional changes can also be cardiogenic causes of syncope. And then thinking about that other group, that non-cardiac causes could still be a minor cause of syncope. Now, the big things that you guys are going to want to worry about, and are they going to have any of these cardiac causes that can put them at risk for sudden death? And if you look at the cause of sudden death in young athletes, the risk of sudden death in high school athletes is about 1 in 100,000 to 1 in 200,000 athletes. And if you look at this series by Bernard in the mid-90s, 90% were male. The mean age is 17 years. And the leading cause in the United States was hypertrophic cardiomyopathy. And hypertrophic cardiomyopathy occurs in about 1 in 500 individuals. And if you look at the second most common cause, is actually anomalous coronary artery. So these are the things that you guys want to screen for to make sure that your patient is not going to end up in this sort of situation. And if you look at the list of causes in this paper published in Pediatrics in 2012, so also breaking up into the structural and functional components, the electrical components, and the other. Hopefully with a combination of screening, questions, exam, getting a really detailed history, and detailed family history, and pick up one of these structural functional problems or any of these electrical problems, and really hopefully capture one of these patients before they end up in a bad situation. So I'm just going to get back quickly to our case. Our case was a patient who had CPVT, probably something that a lot of pediatricians aren't familiar with, but catecholinergic polymorphic ventricular tachycardia. Relatively newer disease, was first diagnosed in the 1970s. This is the importance of the family history question. About almost a third of cases are familial, so it could be a family member who has died suddenly. And usually these patients present with dizziness, syncope, seizures, or even sudden death with exercise. And there's the scary thing about this is you follow this patient their whole life, they've never had any issues. Their first presentation could be an episode with exercise. And the other scary thing is that their EKG is usually completely normal. The echo is usually completely normal. So the only way to really pick this up would be with exercise testing. And most often events occur in the first or second decades of life. And so in your group. So there are really 3 gene mutations. One gene mutation is the most common, is the rhamnine receptor mutation. And what this does is it causes an increase in intracellular calcium, which leads to arrhythmias, typically with exertion, exercise, or adrenaline situations. The treatment for this is beta blockers. This is really the mainstay of therapy, and it really works really well to help prevent episodes of sudden death. Other medications can help as well, flecainide. These patients, unfortunately, would be exercise restricted because there's significant risk of sudden death with exercise. And in some select patients, we would think about placement of an ICD or an implantable cardioverter defibrillator. So the key points that I want to bring up in this case of syncope with exercise would be, we tend to worry about the cardiac causes, although keep in mind that neurocardiogenic syncope is by far the most common cause of syncope in children. That taking a really detailed family histories and personal history is really important in trying to tease out is this cardiac or non-cardiac. And then look for the red flags that I mentioned that could be a sign that the patient needs further cardiac work. Thank you. I'm going to transition back to Heather. She'll go through case number 3. Heather, you're muted.
There we go. Am I on? Okay, perfect. So for case number 3, or the presentation is actually fatigue. And so this 4-year-old presented, she's previously healthy. She had 3 days of fever, up to about 104, cough, rhinorrhea, diarrhea, as well as about 3 episodes of MSS over the last 3 days. So for her day of illness, number 2, parents called her pediatrician's office and said, these are my symptoms. Should we have her be seen? Should I take her in? She's kind of drinking a little bit. And so the recommendation for our nursing line was to say increase hydration if possible. They made an appointment for the next day. And of course, gave the caveat to head into the emergency room sooner if she's deteriorating or not able to tolerate fluids. They recommended an at-home screening test for COVID, which was negative. So day of illness 3 is the day of her office visit. So mom reports worsening fatigue that morning. And then in your office, you can see that the 4-year-old's mildly interactive during the examination, but still conversive and somewhat appropriate for her age. While you're doing her examination, though, you notice that her vitals, her heart rate is quite low. So she is bradycardic. So you send her off for an EKG, and this is the EKG that you come across. So what is this showing? So this is showing complete dissociation between the ventricular rate and the atrial rate. So this is complete heart block. And you can see the ventricular rate is going here about 51 beats per minute. And a little hard to see, it came out a little bit blurry, I apologize for that, but this these P waves here, you can see marching through well without any sort of correlation to the ventricle itself. So with that, you decide to send her to the emergency room. So she's in the emergency room, she makes it there, she gets set up, she becomes more fatigued, and about 45 minutes later in the emergency room, she does this. So these are actually all P waves here, and there's only one ventricular escape beat. So now you know that her heart is quite sick and progressively and rapidly becoming more so. So she's asystolic with very sporadic ventricular escape beats. So this was actually a case that we had a few months ago about fulminant myocarditis. In the ED, she actually got multiple rounds and boluses of epi. And because of that catechol surge, she actually did have temporary return of her sinus rhythm and AV conduction during that time. She did get atropine. And every time the epinephrine would wear off, she would go back into complete heart block or be asystolic. She therefore did have pads placed, and they did transcutaneous pacing on her and gave her a bit of sedation because that actually can be quite painful for anyone, not only children. She was transitioned very quickly to our ICU, our cardiac ICU. And even there, while we were getting her set up, she did have intermittent, what we call loss of capture with the transcutaneous pacing. So the pacing, even at max output with the pads, were trying to deliver the shock, but her heart being so sick was not able to actually create a beat from that. She was cannulated onto VA ECMO, so heart-lung bypass for myocardial arrest at that point. So the WHO definition of myocarditis, of course, is inflammatory disease of the myocardium. Interestingly, it's diagnosed by histological, immunological, and immunohistochemical criteria, which I feel like more often than not, we are very suspect of this diagnosis before we get to any of those diagnostic criteria or states. In terms of presentation, it's actually a bimodal age distribution. And so more often in our neonatal infant toddler range, up until about 2 years of life here. And then you have your another peak in that adolescent timeframe. There are some important gender-based differences in both the presentation and severity. So actually males have a higher incidence of overall cases and actually higher hospitalizations, numbers specifically, but females actually have higher morbidity or mortality. So they end up being a sicker population. And this is dealing with all types of myocarditis, not just fulminant. And we'll get to that in a second. So etiologies, of course, the big one in the news today is infectious. Mainly we think about different types of viruses that are cardiotropic and attack the myocardium itself. But also they're immune-mediated etiologies for myocarditis. And then you also have to think about different types of medications and drugs. So interestingly, I feel like going through pediatric residency, you always hear that Coxsackie B is the main cause and the only cause of myocarditis. And of course, it is a large portion of cases, but actually over the last 10 years or so, we're actually starting to see a shift. And this study did not include the current COVID myocarditis as well, but actually starting to see a shift from the enterovirus population to actually parvovirus and HHV6 being actually more common than adeno and enteroviruses, which I found quite interesting. And this was mainly populations within North America as well as Europe. Of course, there are other types of viruses that we have to be aware of about other regions of the world. So how can these patients present clinically? Interestingly, this can actually be what we call subclinical or asymptomatic presentation. You actually may come across patients in your practice that haven't really felt anything, and then suddenly they have an EKG for whatever reason, and they actually might have a little bit of change on their EKG, signifying that there was something that happened there. These patients then might be sent for cardiac imaging and actually demonstrate different types of fibrosis or changes within the myocardium. They had no idea that they were having any sort of problem within their heart prior to that. Of course, the opposite end of the scale is what we just talked about. So the fulminant myocarditis, this is a very rapidly progressive result, and it can result in cardiogenic shock, sudden death, or pretty significant arrhythmias, which we'll go over shortly. The other portion to kind of highlight is this can actually cause an acute coronary syndrome. So a lot of times when these patients present in chest pain or dyspnea, this actually can be directly resultant from vasospasm of their coronary arteries, usually in about 70% or 71% actually presenting with those symptoms have evidence of this. And parvovirus is actually one of the ones now becoming more common that is classic to present in that nature. So of course you can always look and screen for your patients when you're concerned about myocarditis if they're having heart failure. So the classic symptoms of lethargy, hypoperfusion or cold extremities, pallor, orthopnea. I do want to highlight that Dr. Seth Hollander actually published a study saying and signifying that actually abdominal pain, early satiety, and abdominal pain have been some of the mainstay presentations also in actually heart failure presentation. And this is just demonstrating some diffusion effect from acute coronary syndrome. Ooh, that's quite black. I apologize for that. So I wanted to go over some potential electrocardiographic ECG findings that you can have with myocarditis. So I feel like this EKG is the standard one that you remember from pediatric training. So you have diffuse or even sometimes regional ST segment elevations. So you can see this here, where you can see just diffuse elevations. Some are actually depressed. And so that's signifying globally on a scale that the heart is having perfusion effects. One thing I do want to make a mention of is that you can have actually isolated bundle branch block or actually new bundle branch block myocarditis as well. So even though it is sinus rhythm, you have this aberrant or widening nature of the QRS striation. And as that progresses, or if it progresses, that bundle branch block can become more prominent or actually lead to further types of block. Arrhythmias are common within myocarditis because it is an inflammation of the actual myocardium. It can lead itself to very sinister rhythms, one being ventricular tachycardia, ventricular fibrillation, or torsades as well. And so this is an EKG demonstrating a monomorphic or same type characteristic of ventricular tachycardia. Probably some of the earlier findings that we can see, though, with myocarditis is really just a generalized low voltage of the QRS complexes, as well as diffuse repolarization abnormalities. And so you can see these flattening of the T waves, and really everything just kind of looks muted for it. And that's again signifying that there's an abnormal repolarization going on. The heart electrically is having trouble. So I'm going to switch gears and talk about specifically heart block with myocarditis, since our case did present with that. So AV block actually in one study occurred up to about 33% of their cases. In terms of the high degree AV block, it's attributed to sometimes diffuse as well as severe inflammation of the AV nodal area or infranodal structures. When talking about the aberrancy though, so when you're getting those bundle branch blocks, that dense inflammation is actually usually at the terminal portions of the bundle branch blocks or the bundle branches as it kind of enters the Purkinje system in the ventricles. So when looking at recovery of the patient in general, actually Q restoration was found to be an independent predictor of need for heart transplantation. So if that Q restoration is not returning back to normal, that is more sinister sign. About 67% of patients, thank goodness, do recover even if they do have complete AV block. And this was on an average of about 3 days plus or minus 2.8 days. So you got your EKG, you know what's going on in that amount of inflammation. What do we do next with these patients? So we're really going to take a look by echo to understand the global effect on the heart itself and how it's functioning. So studies have shown that about 72% of patients with myocarditis did have a decreased ejection fraction on echocardiograms. About 64% of them had what we call segmental wall abnormalities, or meaning that one area of the heart is actually affected more than the others. And you can see this dyskinetic septum, or different regions of where it's affected. An initial, not surprisingly, left ventricular ejection fraction of less than 15%, which is very severe, is associated with long-term heart failure. So after this, we can actually shift to a cardiac MRI to look at more specifically the direct myocardial injury. And late gadolinium enhancement is actually one of the protocols that we use to really see do we see any sort of irreversible myocardial injury? And this can be marked by necrosis and fibrosis. And so you can see here, this gadolinium really hangs on to the fibrotic areas of the myocardium after the normal healthy tissue has washed those out. Going to make just a quick mention that there are specific criteria for these imaging strategies specifically for MRI that we go by to see if they're meeting criteria for myocarditis, as we have lots of patients that present maybe at a later time. Is this a cardiomyopathy from a genetic source, or is it myocarditis? It's really helpful to use that criteria to try to tease out those etiologies. So going back to our patient, so she actually received IVIG, 2 grams per kilo infusion, and fortunately she actually did demonstrate return of AV nodal conduction within 24 hours. Looking at her ambulatory monitoring, she actually has not had any arrhythmias on her follow-up studies, and she returned normal biventricular function about 6 months afterwards. So we know that from studies, if we have severe myocarditis, IVIG administration does significantly improve cardiac function compared to controls over the 12-month follow-up timeframe. And I do want to make a mention, one thing that they'll always come back to us and their pediatrician to say is, when can I go back to sports? And so there are actually multiple types of guidelines that we can go by. The Bethesda guidelines from 2005 say restriction for about 6 months. Some newer studies actually from 2019, the European Association, say you can actually repeat a cardiac MRI, echo, stress tests, and ambulatory monitoring in about 3 months. And if everything is returned to normal, they are okay to return to sports. That's still on the earlier side. I think some people and cardiologists would still want them to wait. Right, thank you. And now back to Dr. Stresnick.
That's great. Thanks, Heather. So now we're going to go to our last case. Hopefully everyone can see my screen. So I'm going to talk a little bit about wearables, and I can tell you, I don't know if it's just us here in Silicon Valley and the tech hub that is here, but we've seen an explosion of arrhythmias identified, patients wearing wearables, worrying about arrhythmias that you might have seen on sort of some wearable technology. So we thought we're seeing this. You guys are probably seeing this as well in the pediatric clinics. So let's chat a bit about it. So the case I'm going to present is really a case of wearables and EKGs, and so we'll show the intersection of the two. So patient comes to see you in clinic and they're complaining of intermittent episodes of palpitations. These episodes started about 3 months ago and they're happening about once per week. They can really happen randomly. You'll be sitting there watching TV or just eating dinner, and as Heather mentioned, the first case suddenly start and then suddenly stop. Also, the young adolescent male noticed that these were happening more with sports, specifically playing basketball. Often these would happen, you'd be playing basketball, heart rate wouldn't come down, and would be suddenly racing with their basketball play. Typically, the episodes would last about 10 minutes. One episode maybe lasted 20, 25 minutes, and some episodes lasted about a minute, but on average, they would last about 10 minutes. And they would stop very suddenly. They would start all of a sudden and stop all of a sudden. With these episodes, he noted he felt really tired. He could get a little bit dizzy, but overall felt okay, just really palpitations and some fatigue. So you follow this patient his whole life. He's never had any other medical problems, no past surgical history. He's not taking any medications, no allergies to medications. There's getting a really detailed family history. The maternal grandfather developed AFib at age 65 years of age and had an ablation here at Stanford, but otherwise no real other family history of arrhythmias or sudden death or any other concerns. He's in 10th grade. He drinks coffee and Monster energy drinks about once a week. He's on no other supplements, denies any other supplements or drugs of abuse. And so during one of these episodes, Mom had an Apple Watch on, and he said, "Mom, give me your Apple Watch. I'm going to put your Apple Watch on." So he put on Mom's Apple Watch, and you can see that there's a narrow complex tachycardia at a rate of about 180 beats per minute. He was at the time sitting on a couch doing nothing. And you can see the response from the watch basically said the EKG was not checked for AFib because the heart rate was over 150, and just sort of leaves this sort of unknown, is this an arrhythmia or is it not? Patient then noted on the watch, all of a sudden the heart rate drops to 90. There was a sudden change. So was this an arrhythmia in this patient or was it not? He then had another episode later, and he had an episode that was recorded here. And as you can see on the top strip, you can see this sort of narrow complex tachycardia at a rate of around 150 beats a minute. And then there's a sudden change in the rate. So this pretty clearly showed us that this patient had an episode of SVT, or supraventricular tachycardia, and really documented very nicely on the single lead ECG tracing. So the patient clearly had a nice episode, a nice example of SVT documented by a home wearable. I want to deviate from this case for a second. Let's talk about this patient who also had an Apple Watch. It was a 14-year-old with congenital heart disease and tetralogy of Fallot, and was having episodes of palpitations, usually with basketball, and used Dad's Apple Watch and had this. And so, curious to see what the audience thinks about this. Is this real? Is it not real? You know, just looking at this, there's sort of 3 different areas, and the rhythm looks a little bit different. Here, here, here. So you can see that it looks a little bit wide where the red arrow is. Changes to a slightly different morphology where the blue arrow is, and slows down a little bit where the green arrow is. Patient was playing basketball here. Was this artifact? Was this real? I can tell you when I first looked at this, I was wondering if these are QRS beats in here. And also it's wide. The patient has tetralogy of Fallot and likely has a baseline bundle branch block. So to see a wide rhythm would not be that surprising. Curious to see what most people here think, but I can say that I first saw this, I was a little skeptical. I saw this change between the blue and the green, which made me curious if maybe this was true. So we decided, let's sort of see if we can document this with another monitor. And, you know, just looking at this and says, his Apple Watch says, I feel fine, but according to my new watch, I might be dead, right? So how much can we take as truth from these watches and wearables, and how much is real and how much is not? It turns out that patient, the tetralogy flow patient, was real. So this was the strip I just showed you on the top right. On the bottom, this is an extended monitor, a Zio patch. You can see here a normal rhythm and then whoop, an episode of ventricular tachycardia. So we are seeing more arrhythmias identified by these wearable monitors. You can see the changes there. Now, I showed you some great examples of arrhythmias picked up. But what about, are the watches wrong? And the answer is yes. Sometimes we see a lot of false positives. And I'll give you a great example here. Is a 14-year-old who had a history of atrial tachycardia that we were following. And we have frequent episodes with heart rates of 130 to 150 during these episodes of atrial tachycardia. And wearing a monitor, the wearable said the mean heart rate was 130 beats a minute. However, doing a Holter monitor, as you can see here, our report showed the maximum heart rate on the Holter monitor for that 24-hour period was 121 beats per minute. And the watch was telling them that there was 130 to 150 beats per minute consistently. So we also seen a significant number of false positives here. And so, really teasing some of these arrhythmias out can be a bit of a challenge. So I wanted to step back for a second and just talk about wearables in general. Most of this data is in adults, but I think it is interesting and also pertains to our kids in many ways too. Many of you are probably aware of the Apple Heart study. It was done by one of our colleagues on the adult side of Stanford, Marco Perez. It was a large-scale assessment of using the Apple Watch, really primarily to detect atrial fibrillation. They enrolled almost 500,000 participants, and about 0.5% received an irregular pulse notification while wearing the watch. Those older patients, over 65 years of age, had the highest rate of notifications, over 3%. And interestingly, they found a pretty good percentage of these who had irregular heart notifications on the Apple Watch turned out to be atrial fibrillation. 84% of those ended up having atrial fibrillation. And then in those patients where a notification was of an irregularity was identified, patients wore a Zio patch, and 34% of them had atrial fibrillation on the Zio patch. So it turns out the smartwatches are actually pretty good at picking up atrial fibrillation, specifically in adults. It's a really nice study looking at the Apple Watch in the adult population. And so we know that we're all pediatricians, and our kids are not just small adults, well, at least usually not just small adults. And we know that atrial fibrillation is incredibly uncommon in our children, especially really young kids, right? So most of our kids are going to have SVT or even potentially episodes of clinically stable ventricular tachycardia. So the corollary after that AFib study, the same group looked at non-atrial fibrillation. And they found that actually the Apple Watch is pretty good, that 40% of those patients who had short episodes of SVT or pauses, or even PACs or PVCs, that the Apple Watch could pick those up as well. Again, this is in adults, and there's very little data on this in children, but these are the arrhythmias we would typically see in children. And so perhaps the watches are pretty good at picking up arrhythmias other than atrial fibrillation that we would see in kids as well. Let's talk a little bit about the monitors that we would typically use. So the classic monitors that we would use are the old-fashioned Holter monitor, which is 24 to 48 hours of monitoring. As you can see, there's all these stickers on, there's wires that come down, hook onto the belt. So a lot of our patients would feel uncomfortable wearing them. People would ask, what do they have that for? And could make kids a little bit uncomfortable. In addition to being bulky, they're visible and it could make kids uncomfortable. Now, the current landscape of the monitors that we use are much nicer, right? So on the left is the example of the Zio patch. There's a Cambardi monitor, a Biotone monitor. So these often are stickers that sit on the chest. Usually no one can see them when they're covered by a t-shirt, and can have extended rhythm monitoring. So usually about 14 days. Some of the monitors can be up to 30 days. And really, our goal in this patient with palpitations is to document the rhythm during one of these episodes. So we can see, is it an arrhythmia versus non-arrhythmia? I can tell you the vast majority of kids we see with palpitations do not have an arrhythmia. But for whatever reason, they feel the heart beating faster or different during these episodes. These monitors will tell us for sure whether you do or not. And recently, we've seen a big surge in some of the newer monitors, the LiveCore monitor, which you can get a single lead EKG, and the Apple Watch, so newer versions where you can actually physically obtain a single lead ECG tracing. But then we could see and we can help identify, is this an arrhythmia or is it not? And we used to do 24 to 48 hours of monitoring. And this is a paper we published on congenital heart disease patients looking at extended monitoring. And we know that the longer we keep these monitors on, the more likely we are to pick something up. And you can see this sort of Kaplan-Meier curve as once we got out past day 2, which is our traditional 24 to 48 hours of monitoring, you can see we still pick up a lot of other arrhythmias in these patients with congenital heart disease with extended monitoring. So the newer monitors are great for picking up some of these arrhythmias more long term. I know you guys have probably on the pediatric side seen this in terms of neonatal monitoring. And the outlet is a big one. There's a whole bunch of other monitors. Heather and I have both seen patients who have had SVT picked up on the outlet. And I think we're not trying to endorse any particular monitor here. And I think we've also seen a ton of monitors that have picked up arrhythmias that we've never been able to identify any true arrhythmias, and probably just artifacts. But we had some of our SVT patients who have been able to, especially babies, where if this is me having an episode of SVT, I would come in and complain of palpitations. With babies, this can be challenging to determine when they're in SVT or they're not. And we have had some success seeing some of these arrhythmias picked up by the outlet and other monitors. And there is some data on this in children. So Peter Aziz, who Heather and our colleagues on, who's at Cleveland Clinic, and looked at this about 100,000 infants, looking at about 5,000 episodes of tachycardia, looking at a rate of over 240 for greater than a minute. And on these direct-to-consumer heart rate monitors, about 2.5% of patients seem to probably have an episode of SVT. It is interesting that this is significantly higher than other population-based studies. There's a big population-based study in England that really the likelihood of SVT in an infant is probably about 0.25%. So this monitor seems to pick up more. Some of that artifact probably is some of that selection bias, where there's some families who kids had SVT and they're more likely to be wearing these monitors. Perhaps that is the case as well. We do know there is some data suggesting that these monitors can be helpful to pick up arrhythmias in infants as well. I want to talk about the 12-lead ECG. All these ECGs that I've showed you so far often give you a single lead ECG. And so much of the work that we do in cardiology is really, Heather showed some great examples of myocarditis. We're looking at the full 12 lead, all the precordial leads, the limb leads, taking us a full sense of the heart. And so this is the sort of classic 12-lead ECG that we would do in clinic, hook up all these different stickers, and then get a full 12-lead. And the pandemic changed that. Just as it changed your practice in general pediatrics, it really changed our practice as well. Hard for families to come in and COVID, or feeling like COVID, or just concern about getting sick overall. And so we did sort of think about branching out and other ways we can get 12-lead ECGs. And the CardioMobile is one device that can actually give you a 6-lead EKG. And it's a nice example of via a very limited, small size piece of equipment that can give you multiple different leads that can be helpful for us. But there are also, I just mentioned these two newer companies that are able to provide in-home portable 12-lead ECGs. And so QT Medical and Smart Heart Pro. This is one that we have used, the QT Medical monitor. That you download an app for your phone, you get mailed this sticker that sits across the chest and can give you an ECG at home, and a full 12-lead ECG that then can automatically be sent to us, and we can see it actually in an automated digital fashion. There is actually data on this QT Medical device in neonates. So this was actually done by a pediatric cardiologist in Southern California, and he looked at about a little over 2,500 newborns. And they were pretty quick. You could do them in about 10 minutes. And they compared the ECG of this sort of patch ECG versus a standard EKG, and the ECG quality was excellent. And so this is probably some journal of electrocardiology. And so there is some data in newborns that these ECGs work pretty well. We started using this during the pandemic, and we've done about 163 EKGs in 33 patients at a mean age of 14 years of age. That we put these orders in Epic, that gets mailed to the family. From an equity standpoint, right, if you don't have a phone, the company was excellent about sending a phone to the family as well, to make sure that those families that weren't able to afford a typical phone were able to still do this as well. And the EKG quality we had was excellent in about 2/3 of the patients. The whole thing to download the app, put the EKG on, do the EKG, and do the sticker, and we actually record the EKG, took about 45 minutes. And most people found it really easy to use, and sometimes it saved an hour trip to the hospital to get an EKG. So there are other alternatives in doing some of these ECGs at home in select patients. So back to our case, the patient came in with a wearable device, had an Apple Watch, identified this episode of SVT, and we confirmed that the patient did truly have SVT at EP study, came to the EP lab, and we were able to find and ablate this patient and cure them of the episode of SVT. So the Apple Watch sort of picked this up beautifully, and you may see some more of these cases. So the key points here are, we're seeing a remarkable growth in the number of patients that we're seeing with wearable monitors and the tracings on those. We know that the market in general is exploding, and though there isn't a lot of product that is specifically geared towards kids, we're seeing secondarily how it can affect kids, both in a positive way, picking up great arrhythmias, but then also a lot of false positives, saying it's atrial fibrillation or other things that are incorrect. So I think they can be helpful, but we have to be careful sort of how we interpret the data, how we analyze the data. And I think there's an opportunity for a tremendous growth here going forward for our kids. So we're not at the point yet where we can say our iPhone is our primary care physician. I'm sure you guys have seen this. So that's all I have. I think those are all our cases, and we're happy to answer any questions or help in any other way. I see Heather was able to answer one question in the Q&A. So this other question was that the study enlists people with any known heart conditions. If that's the case, although it's not 100% accurate, are wearables reinforcing good habits by the patient to be aware of and to report unusual readings? I think it's a great question. The Apple Heart study was not just people with known heart conditions. There's actually anybody who had an Apple Watch who wanted to enroll. I think these wearable technologies we're gonna see not just from the rhythm perspective, but detecting movement, encouraging people to move. I think the O2 monitor part of it, but in the newer Apple Watches, how is that gonna impact what you see and what we see? So I think it's an excellent point that the attendee brings up, is that there's going to be a lot of pros and there's going to be some cons of these watches, and I think they can help patients with congenital heart disease and also patients who don't have any.
All right. There were two other questions that I was addressing in the chat that I can do live as well. And so the same question for palpitations. If palpitations only occur infrequently and last for 1 to 2 minutes, should they be worked up if previous Holter monitor was negative? So I think this is a great question. I think it's probably one of the most common things that we encounter. And it really comes back to how nervous you are about the presentation of these palpitations. Are there any red flags that you're concerned about is a big thing that I would ask ourselves. And so if I have a normal Holter monitor for this patient, and it is pretty benign of a presentation, I can reassure them that the Holter monitor that I see doesn't show any sort of abnormal rhythms just at baseline that they weren't aware of. But I always make the caveat that I can't necessarily correlate their actual rhythm with what they were experiencing. And so at that point, I start to, if the patient wants to pursue this, and I also want to pursue this for them, then I also talk to them about different types of longer wear monitors, such as the 30-day or event monitors, to try to capture it. The other question that I have answered in the chat was, are there any benign causes of low voltage on EKGs, and should these patients always be worked up? I think this is a really great question. So low voltage on EKG can be because of a lot of different things. And so one thing is by body habitus. And so if you have a quite obese individual, that can actually affect the overall voltage of the EKG. Also, pericardial effusions can create a low voltage scenario kind of globally on an EKG as well. I will have to say, though, that repolarization abnormalities with T-wave flattening or inversion, while it's pretty non-specific, it can be abnormal. And so there are many different reasons as to why that can happen, but if it is a change from their previous EKG, they have any sort of infectious history in the last few months, or having a murmur or anything else concerning, I think that patient at the very least should have repeat EKGs, but more often than not have a good physical exam and potentially be sent for echo.
I can answer the next one. One of the questions was, can you speak to screening ECG for athletes and sports physicals? And I think what I'll do is I'll share my screen again and go back to one of my slides that sort of lists the cause of sudden death. Because I think it's a great question, and I think it's a it's not coming back, but I think screening ECGs are a bit of a double-edged sword in my mind. I think I mentioned before that the risk of sudden death in high school athletes is about 1 in 100,000 to 1 in 200,000 high school athletes can have sudden death. And when these tragic and horrible events happen, they're devastating clearly to families, they're devastating to communities, and really just tragic. And as I pointed out before, that I think it puts, again, you, the pediatric community or general pediatricians, some of these presentations can be the first sign of anything wrong is an episode of sudden death. And I think that's the scary thing about a lot of these inherited arrhythmia syndromes and some of these cardiomyopathies, is that could be the first sign. And through no fault of you as a pediatrician, that patient with CPVT, if they never had an episode of syncope, you would not have known that they had CPVT before. But the scary thing is in CPVT, that case, the EKG will be completely normal. And so in some of those conditions, right? So what are the conditions where you would see an abnormal EKG? Hypertrophic cardiomyopathy, ECG typically is abnormal. WPW, the ECG is typically abnormal. Long QT, typically abnormal, although about 20-30% of patients can have a normal EKG at some point, even though they have long QT, and it still could have a channelopathy and inherited long QT syndrome. So the ECG is not perfect. Coronary artery anomalies, which is the second leading cause of sudden death in young people, EKG will be completely normal. And so Brugada syndrome, which is another one, you can have one EKG that's completely normal, and the next EKG looks like Brugada. And so I think the EKG is a pretty good screening tool, but it has significant limitations of picking up some causes of sudden death. I think then the flip side of that is the false positive rate. And the sort of anxiety, the limitations of sports to say, oh, the QT is 450 in this male, it's very borderline. Do you then need to send it to a cardiologist and get worked up when the vast majority are completely normal? So I think as a screening tool, there's significant limitations to ECG based on some of the diagnoses you're not going to be able to pick up, number one. Number two, the false positive rate is going to be quite high. And so I think I have a lot of mixed feelings about sort of universal ECG screening for that reason, because I think the false positive rate is so high, the costs of that are going to be tremendous. And I think we have to be careful about just screening every single person with an ECG. Again, I know that it's so devastating when this happens and there can be no other signs of abnormality. ECG can be helpful and screening ECG programs can be helpful at picking up some of these conditions and might save some lives too. So I think I'm more on the skeptical side of whether we should be screening every single athlete with an ECG, but I know there's a lot of controversy and a lot of debate about this topic. That was the last question.
Excellent. Thank you both very much for sharing your insights on this topic with us. Before we wrap up, if there are no other questions, perhaps we'll just end by asking both of you, if you can share with our audience, what's one takeaway from this conversation today that our participants should walk away with from both of the cases that you discussed? And so I'll start with you, Heather, and then go to Scott.
Yeah. Well, first of all, thank you again for having me and having us speak at this conference. We're really excited to do so. I would say that the one thing to take away from this is exactly what you guys are doing. So you're talking with these families, you're bringing them in, you're following them over a longitudinal time, and their clinical course can really change dramatically, even in a short period of time. So having that follow up and following these kids through to see what their clinical course is and providing and guiding them to the right treatment, that right treatment level is crucial. So I think that all the work that you put into seeing these patients as pediatricians does not go unnoticed. And I know that from the families as well.
Thank you.
I would say in some ways, my job is way easier than general practitioner's job. But someone comes to me with palpitations, I have a set of tools that I can use and then say, I'm going to do this monitor and I'll be able to tell you, we can pick up one of these episodes for sure, whether the patient has an arrhythmia or not. And, I think you guys are on the front lines seeing all of these kids. And I think we can focus on some of the cases where, we've seen picked up serious heart conditions. I think the keys are, most patients with syncope don't have a heart condition. And that's why doing a detailed history, really getting into the nuts and bolts of what caused that episode, and really understanding what are the red flags that should warrant further workup by a cardiologist, I think are the key. And the same thing sort of with that palpitations. The vast majority of kids with palpitations that we see don't have an arrhythmia. It's a matter of, do you have any other clues that this could be worrisome? That's when it's sort of best to refer to a cardiologist. And I think, I think in some ways your job is harder than ours. So we can sort of see a discrete set of problems, sort of answer those questions. I think I have a lot of respect for all the pediatricians in the community who can sort of really do a great job of really teasing out these little signs and subtle symptoms that would warrant further workup that can really make a difference for these kids.
Fantastic. Well, again, thank you both. And thank you to our attendees for participating in this afternoon session. I just want to remind people that the Children's Week conference continues tomorrow with a discussion on gastroesophageal reflux disease in the afternoon and a great panel conversation on the transition of care that's happening in the morning as well. So again, thank you all very much for your time today and have a great rest of your afternoon.
All right, thank you.